Hi, everyone. Welcome to the Systems for Action Research Program in our Research in Progress webinar series. We are going to wait just another minute or so to get started. I see our participant numbers are climbing, so just bear with us for another minute or two and we'll get started. Again, welcome. Thank you for joining us today. You are with the Systems for Action Research Program in our regularly scheduled Research in Progress webinar series. My name is Glenn Mays. I'm a professor here at the University of Colorado in the School of Public Health, and I direct the National Program Office for the Robert Wood Johnson Foundation Systems for Action Research Program. If you are new to Systems for Action, we're a national research program funded by the Robert Johnson Foundation, and we study innovative ways of helping medical, social, and public health systems work together, and in particular, align their efforts toward the shared goals of advancing health equity, dismantling forms of structural and systemic racism that tend to get embedded within our health and social systems. Um, we fund research projects all around the country, testing innovative ways of aligning medical, social, and public health systems, including studies of innovative financing and payment mechanisms, innovative organizational and governance mechanisms, innovative staffing and workforce strategies, data and information integration, many different strategies or potential solutions that can help to defragment our health and social systems and help them work together toward the goals of health equity. In this webinar series, we come to you about twice a month, and we feature one of the research projects that are funded through our program. We give that research team a chance to update us about the progress in their study and what they're learning. And we always save time to have some Q&A with the research team as well, and those of you who are with us today. Today, we're very fortunate to have a research team based in Minnesota at University of Minnesota who have been studying an innovative financing mechanism for supporting multi-sector investments in social determinants of health. And so really excited to check back in with this research team to hear what they're learning through this project. A couple of housekeeping issues. Number one, all of our participants are muted. We have a large number of folks with us today, so you won't be able to speak, but you can ask questions, and we encourage you to ask questions, and you can type your questions into the Q&A box. You should see a Q&A icon down at the bottom center part of your screen. Type that, click on that box, type your question in at any time during the webinar. We'll get to as many of those questions as we can. If we don't get to your question by the end of the hour, we'll also be posting some written responses to any questions we don't get to later. Second, we do record these webinars, and they're posted on our website at systemsforaction.org. A lot of great resources up on that website, including these webinar recordings and products, findings, presentations from the more than 40 research studies that we supported to date through this program. So also we post funding announcements and other kinds of events for Systems for Action. So definitely get to know our website at systemsforaction.org. And with that, I think I'm going to hand it over to our research team, and I'll let them introduce themselves. We are fortunate to have several members of the team based in Minnesota with us. So let me hand it over.
All right, great. Well, thank you very much, Glenn. So my name is Richard Thacker. I'll be starting out the presentation today. So I'm part of a broader University of Minnesota team, and we're very fortunate to have the support of the Robert Wood Johnson Foundation for a set of projects which broadly are trying to look at the effect of creating a financial structure in order to increase investments in social determinants of health. So this project in particular is one of, I mentioned, a set of projects. So it's joint work with myself, my colleague Pinar Karacamandic at the University of Minnesota, who's in the finance department at the Carlson School of Management, and Francis Fang, who is a graduate student in the applied economics department at Minnesota. So what I'm going to do is I'm going to go through what we have so far in our project, where we're trying to do a quantitative simulation approach to kind of get at a different angle into this problem. And then afterwards, I'll hand it over to Lorena De Leon, who's going to talk a little bit about some work that she's been doing over on the East Coast to actually implement these in reality. So I'll try and kind of keep my presentation on the short side and then hand it over to her because I think she has a lot of valuable insights into current efforts to actually implement some of these interventions. All right. So let me start with just a broad overview of the project. So I mentioned this before, but just social determinants of health, I'll abbreviate it SDH, or often abbreviate SDOH, are conditions in people's environments that affect their health and well-being. So that's a very broad term. It's been recognized to impact health equity and also be very important in terms of driving adverse health outcomes and healthcare costs. So to kind of give some concrete examples of some of these social determinants of health, you can think of things like food insecurities. So someone doesn't have access to a stable source of food, it starts to adversely affect their health, and then that in turn drives adverse outcomes and then increases in healthcare costs. But there are many other examples. Examples include lack of access to housing, education, lack of transportation. So if someone needs to get to a doctor's appointment, they're not able to. Safety, employment, structural racism, and a really wide variety of socioeconomic and environmental factors. Now, in the last number of years, social determinants of health, SDH interventions, so trying to make investments to address some of these determinants of health, have been recognized in the literature and also empirically as being important. In particular, they're important for state Medicaid programs because the Medicaid population in particular has a lot of SDH complications that interfere with care. So we basically think that this population in particular may be especially exposed to these social determinants of health, which especially adversely impacts their health. Now, Medicaid in the US covers over 70 million individuals. It accounts for a big chunk of healthcare spending, for about 20% of the spending. And in particular, to serve Medicaid populations in different states, we have managed care organizations, which I'll abbreviate as MCOs. So these are organizations that they are attached to the Medicaid funding, and then they're the actual ones that are serving the populations. Now, it's been observed, and we see in practice, that a lot of these organizations are actually enthusiastic about implementing these sorts of SDH interventions. They recognize that if they make these sorts of investments, it can improve their own populations, help them save costs, and improve health in general. So in particular, we have limited evidence, and Lorena will opine on this a little bit further and show some additional evidence, but we do have some initial evidence that these sorts of initiatives, if these MCOs actually invest in them, end up being positive ROI, so a positive return on investment for these organizations. So this is kind of the high-level overview of what we're trying to do in our broad set of projects. But there are a number of challenges for bringing these interventions up to scale that have kind of been observed. First of all, the benefits, in other words, the cost savings to the organizations that are providing care for Medicaid, they tend to accrue over a long period of time, but a lot of these interventions, such as investments in housing and transportation and so on and so forth, they require substantial funding upfront. The money needs to come from somewhere, and a lot of times it's a lot of money. And they may be averse to actually making these investments. Another issue that's been observed is that there can be volatile Medicaid enrollment patterns. You have coverage changes, eligibility switches, people can potentially change plans, new people are coming into the plans. And so in general, there can be churn, which makes the cost savings risky. And so in the literature, this has been labeled the wrong pocket problem, where, for example, if one organization makes an investment into a Medicaid intervention, the cost savings don't accrue only to that organization. They may accrue to other organizations, and then you have a free rider problem, as we call it in economics. The big picture takeaway here is that it's been observed that these investments are good. They're good for patients. They can save money for these organizations, but we don't see enough of them. So there's underinvestment in these interventions. And so this is kind of just the broad question and broad problem that we're trying to look at here, which is we should see more of these interventions. Are there ways that we can form structures or think about providing incentives to increase these types of interventions? Okay, so in prior work, so as part of the RWJF grant, we published a paper in Health Affairs that proposed at a pretty high level and that provided some examples of one structure that we think may be able to help this issue. And we call this a social bond. Now, the idea behind a social bond is that this is a financial instrument that is provided to investors in capital markets, so same types of investors that might invest in just regular stocks or bonds. And by these investors investing in this structure, they're providing money that can be used by the managed care organizations to directly do these SDH investments. And so the idea behind this is that one problem is that it can cost a lot of money. Finance in general is very good at shifting large amounts of money between individuals and between organizations. And so this is basically a way to just provide money for these SDH investments. Now, this diagram shows one way this could work. The idea behind it is that you have, let's say, two MCOs that are providing care to a certain patient population. They want to invest in some sort of SDH investment. Again, this could be transportation or housing or another type of investment. So the idea behind this is that these MCOs, they form a separate vehicle here. For the purposes of this illustration, the vehicle isn't really important, but it's kind of just for pooling funds together. The vehicle issues a bond to investors. So investors buy this bond. Some cash flows are promised to the investors at some point in the future over time. And then the investors give money by buying the bond. And then this money is then provided and put into these SDH investments. So this is the basic idea behind the social bond. And again, the idea behind this is that by making these SDH investments, it benefits the MCO because it provides cost savings. The population health improves, and then it's less costly to provide care to this population in the future. So in this particular project that I'm going to talk about today, I'm going to provide some evidence for what we've been working on the last number of months. It's providing empirical evidence for the economic feasibility of a type of structure like this. So in particular, what we try and do is we try and build a simulation model that tries to simulate a patient population. We try and calibrate the model with, to the best of our knowledge, some estimates in the literature for some of these costs and potential improvements in health. And what we try and show in the model is that this sort of structure can be feasible from an economic perspective. So in other words, it can be attractive to investors. Investors can actually see a decent rate of return and want to invest in this type of financial instrument. And then on the other side, it can be incentive compatible. So in other words, the MCOs, the managed care organizations, may actually want to do this sort of vehicle and participate in this financial structure. So the main goal here is to provide numbers to show that this can be economically feasible. So what do we do? I'll just give a broad overview of what we have so far. We construct a Monte Carlo simulation model. We simulate a market with managed care organizations and patient populations. They have health conditions that evolve over time. The key takeaways are as follows for what we have. First of all, what we have is that if you have a single MCO, health improvements from the patient population, if they make these investments, lead to cost savings over time. Again, an example, and there are many different examples, might be that you have diabetes patients that need regular dialysis. They skip it sometime because they can't afford the transportation costs. So the investment could go towards providing transportation for those patients. Now, a number of different time periods in the future, though, are required to offset the initial investments. We show the evidence of the wrong pocket problem within the context of our simulation. So if you have multiple MCOs, switching of patients and churn of patients and new patients entering make the investments risky. And so the financial performance can be worse than when the investments are made. So the idea behind this is that the MCOs that do not invest benefit from the savings from the other investments. And so they have an incentive to not do those investments in the first place. And then finally, we showed that if we introduce a very simple SDH bond, a social bond that basically ensures that there's continuous investment for all the patients, this can improve the overall health of the patients. It can reduce costs to the MCOs and help to solve this wrong pocket problem. And the MCOs, one of the insights is that they can all benefit from this and all have an incentive to do this. And the incentive to actually participate in this is stronger than the incentive to just sit by the sidelines and not do it. So we show that the long-term profits can be higher than the no investment case. The overall punchline here is that it's economically feasible, and actually these MCOs have an economic incentive within the context of the model to actually do these investments. Okay, so what I'm going to do, the model has a lot of technical details. I'll show some numbers for the results of the model. I'll try and stay at a pretty high level to kind of just provide a little bit more insight into the intuition of what's going on here. Let me give you first a very high level setup of what we do in the model. What we start with here is we have a healthcare market. We start with 3 managed care organizations. And then we have 5 periods. So the way we think about these periods is that it's a market that lasts over 5 years in the future. So that's the horizon of the model. Each managed care organization has its own set of patients initially. So they have their own set of patients within the market that they serve. And each patient's health evolves over time. And the idea behind this is that each patient, what I mean by each patient's health evolving over time is that there's some chance that a patient can fall into severe illness. So in other words, a patient can fall very ill, and then this results in a higher cost for the managed care organization. And so the managed care organization can make a costly SDH investment, just meaning it's an SDH investment. It costs a significant amount of money per patient, which I'll provide some specific numbers in a minute. And these SDH investments improve patient health. And the idea behind that is that by improving patient health, it reduces the likelihood the patient will fall into a severe illness and therefore cost a lot more for the managed care organization. With this basic setup, we show some initial results about kind of the incentive that an individual MCO can have for actually making an investment. We then introduce a simple social bond that basically commits all of the MCOs in the market to making these sorts of investments. And then we show that this sort of bond can be actually attractive for the MCOs to participate in. Okay, so that's the very high level setup behind the model. I'll just briefly go into a few details here. So as I mentioned, we generate a hypothetical market with 3 MCOs. There's an initial market share of patients, and each of these patients has an initial random health score. So think of each patient basically has just a different level of health to begin with, and this level of health is random. We're going to simulate the model many, many times, and so we'll provide an average over time with regard to the estimates. In each of the periods, and again, there are 5 periods, this is how the model works in particular. So based on the current health score age, patient has some probability of light illness. You can think of this as just maintaining the patient's health, or the patient's health goes down just slightly each time. And then some probability of severe illness. And again, the cost of the MCO is higher when there's severe illness. Each managed care organization makes or has the potential to make an SDH investment in each period. So each MCO can choose whether or not to make an SDH investment. In the model, we're agnostic on exactly what this investment is, but it could represent, as I mentioned, a number of different things. The individual health score is then adjusted, and so if there's an SDH investment, the health score goes up by a little bit because patient health improves. We then calculate retained premiums to each managed care organization, and then patients are potentially allowed to switch with some probability to a different MCO or drop out of the MCO or stay at the same MCO. And then in the next period, the patients and the MCO repeat this process until the end date of the model. So that's the more some of the more specific details on the model. This is how we calibrate the model. Now, I realize I'm putting up a lot of different numbers over here. I just want to kind of highlight a few different things that we do here. In some cases in the literature, it's not entirely clear what the parameter estimate should be. We try our best based on evidence that we see to calibrate the model and pick particular parameters here. So for example, the initial value of the health score, we try and look at HQR, which has a self-reported health status. Basically, are you in very good health, fair health, bad health? And then we look at a distribution of those values and then basically parameterize this based on the distribution that we see there. For example, the cost of severe illness, we take again from HQR based on different health buckets and the average cost for people in these different health buckets. So the main idea here is that if you fall into severe illness as a patient in the model, it costs a lot more for the MCO. Premiums per patient per year we get from Medicaid spending data and enrollment data. We assume that the cost of an SDH investment is 5% of the total premiums. Now, again, this can change a lot for a different SDH investment. Some of our next steps is to show how much this can vary with particular sets of investments, and we're hoping to get some more detailed data for that. We assume, and I'll show a little bit of sensitivity analysis to this, that the health score, again, moves up a little bit with investment or moves down slightly without investment. And again, this health score impacts the probability of a severe illness. So the lower the health score for a patient, the higher the probability the patient will fall into a severe illness. We then make some assumptions on the initial market share of each MCO. So this is to provide some analysis for differences between the MCOs. And then we have some probability that a given patient will switch to a different MCO. So we have for the first MCO, for example, there's a 90% probability that a given patient each year will stay within that MCO, but some probability the patient will move to a different MCO. Then we'll run the simulation 1,000 times, and then we'll have 10,000 patients each time. Okay, so we calculate retained premiums per patient for each MCO in each period. I'll briefly go over some high-level results for 3 different scenarios. One is that no MCO makes an SDH investment. The second scenario is that one of the MCOs makes an investment each period. The second one sometimes invests, and then the third one never invests. And then finally, I'll show some results that all of the MCOs invest using this social bond structure. Now, we have different scenarios. You could think of different sorts of combinations of these, but this is kind of to give a high-level intuition of what's going on. Okay, first set of results here. We use a discount rate of 8%. I'll highlight a few things here. So this is a case where none of these MCOs make an investment. So what's happening over here, it's pretty mechanical in a sense that basically the retained premiums for the patient population in general are going down a little bit each time. The reason is that we make an assumption that the health score goes down a little bit each time. And you can see this on the right graph for each of the periods. And these are averages for the health scores on the right, retained premiums per patient on the left for each of the periods here. And then in the parentheses are standard deviations across the simulations. Then at the bottom, we have discounted retained premiums per patient for each of the MCOs. So the main highlight here is that patient health scores decrease over time without any SDH investments. And you get basically very similar discounted retained premiums per patient. So that's kind of a baseline scenario. The second scenario here, which I think is a little more interesting, is what happens when you have just one MCO doing these investments consistently each period, but then one MCO doesn't do anything, and then the second one does it sometimes. And so what we have here is that we have for MCO1, the one that does the investments, we have an improvement in the retained premiums and an improvement in patient average health. But one of the interesting things that we have here is that even though MCO3 is not making any investments, the decline in retained premiums is not as much as the previous scenario. And furthermore, the patient average health is roughly the same. And the intuition behind this is that MCO1 is making some investments that improve patient health. Some patients are turning and then moving over to MCO3. And so MCO3 is actually reaping some of the benefits of these investments. And interestingly, if you look at the discounted retained premiums per patient, so it's taking the present value of all the future retained premiums for each MCO, it's actually the highest for MCO3. And so there are a couple of takeaways from this. One is that MCO3 is benefiting, and actually MCO3 has an incentive to just not do anything, to not invest at all. And these retained premiums are higher than even scenario one. So incentive-wise, MCO3 is just better off just sitting by the sidelines, not doing any investment. MCO2 also benefits more than MCO1. So MCO1 is basically doing most of the work, but then the patients are moving between some of the MCOs, there's some dropout and new patients, and so MCO3 is benefiting. The last set of results that I'll go over here is what happens if all three MCOs invest, and they invest due to a social bond structure, where basically they get money up front, they do all of the investments as part of the social bond in each period, and then they pay back the bond over time in the future at some interest rate. Now, what we have here is that when all of them invest, even though they have to pay back the cost of the bond over time, and again, one of the important things is that they don't have to put the money up front for these investments. It happens in the future after they've already gotten some of the cost savings from doing these investments. What we find is that in all three MCOs, patient health improves, retained premiums improve, and then discounted retained premiums per patient also improve. And so there are a number of other results. I won't go into all of the details here, but I'm happy to answer some from Q&A. But the increase in discounted retained premiums versus the no investment scenario is about 12% for what we have here. It's higher for MCO3 than in the second scenario. And what this means is that MCO3 would actually rather participate in this structure than just sit by the sidelines, as we saw in scenario 2. And interestingly, we had the greatest percentage total increase in premiums for MCO3. So one thing to note is that MCO3 actually had the smallest initial market share. So I think this is an interesting angle of the results, that even though MCO3 had the smallest initial market share, it actually benefits the most from participating in this structure. But one thing to note is that MCO1 still benefits. Put some numbers here. The average internal rate of return here is about 8.9%. From this bond, and then this has positive net present value for the MCOs. So in other words, the MCOs would have an economic incentive to participate in this. I apologize. It looks like my PowerPoint just froze. Let me try and put in something else here. Okay. Now, we're currently working on some extensions and robustness. This is one example of robustness that we're currently doing. This is calibrated based on an old set of numbers. We recently got a new set of parameters based on literature to calibrate. But I just want to highlight a couple of, I think, interesting effects here. First of all, the threshold for a health increase for this investment return to be positive. The punchline here is that health scores have to increase by a certain amount due to the SDH investment. So in other words, this isn't always going to be unilaterally beneficial and provide a positive rate of return. The SDH investment actually has to have some sort of impact. It has to have a substantial amount of impact. There's also, we've looked at a few other scenarios, for example, heterogeneous effects of SDH investments by patients, so showing that some patients are more sensitive to investments than other patients. In effect, we get an amplification of the results in some cases for there. We also look at heterogeneous effects of SDH investments by managed care organizations. So in other words, making an assumption certain MCOs are better at implementing the investments than others. And that gives a little bit of interesting results, as the ones that are better at implementing the investments should have a higher relative share of the investment. Okay, so I'll conclude here and then I'll hand it over to Lorena. At a high level here, what we've done is developed a simulation model of healthcare markets that serve Medicare populations. What we try and show some evidence of is the wrong pocket problem can provide a disincentive for managed care organizations to invest in SDH investments. We provide evidence that a social bond, which raises money from investors, commits MCOs to the use of these funds for the investments, can potentially improve patient health, increase profits, and actually be something that's attractive for MCOs to undertake. Now, we have a number of next steps. We're hoping to get all of this done in roughly the next month, but basically it's a lot of robustness. So showing different assumptions for market shares, difference for a market with 3 MCOs compared to 2 MCOs, showing how much of a different effect this churn of patients between MCOs can make for the analysis, comparing the rate of return from the investor's point of view compared to other similar investments, and provide evidence that investors actually would want to invest in this as opposed to somewhere else. And then the potential for, say, local governments or state governments or just in general government guarantee can affect incentives both for investors as well as for the MCOs. So thank you very much. And then I'll hand it over to Lorena, who has a number of different comments and I think is doing something very interesting related to these SDH investments.
Hi, Richard. Thank you so much for the opportunity to support, some of the work that you guys are doing and also share what we're doing at Maryland Physicians Care. Let me go ahead and share my screen here. I have some slides. All right. Into presentation mode. So one of the things that I would share is who is Maryland Physicians Care. Maryland Physicians Care is a Medicaid managed care organization in the state of Maryland. We're the 3rd largest MCO in the state, and we serve approximately 245,000 Medicaid members statewide. We're in a unique situation. We're owned by 4 Maryland hospitals. So UPMC Western Maryland, which is, a more national a plan, as well as Meritus Health, which is local, Holy Cross, which is owned by Trinity, and St. Agnes, that's owned by Ascension. So lots of big players, right, have taken a 25% stake each in Maryland Physicians Care. We're a network of about 60 hospitals, 3,200 PCPs, and 32,000 specialists. So all of our owners are nonprofit. And so it gives us a really unique perspective, because everything that we make as far as profit goes, which is very slim. And that's one of the points that I think we need to highlight is the profit margin on a Medicaid population is very, very small. And so being able to fund SDOH programs becomes a significant problem for us. We know what the value is, right? We know that when you think about health outcomes, 20% of what we do, right, in the clinical aspect is the clinical care and actually has an impact on health outcomes. And 80%, to what Richard highlighted in the beginning, was our social, economical, or environmental factors. So where you play, pray, eat, sleep, and what access to resources you actually have. I like to go back to the basics of Maslow's hierarchy of needs, right? We can screen people for social needs, but if we don't have the funding to actually address those social needs, we don't help them move up that hierarchy of Maslow's theory, right? Patients also struggle to comply with their treatment plans as a result, right? If I have diabetes and all of a sudden I don't have access to nutritional foods, you're never going to control my hemoglobin A1C. Additionally, if I don't have transportation, I can't get the medications that I need. So it really becomes a challenge for patients if they don't have their SDOH needs met. We lack sustainable funding in order to be able to address this. And, the one thing different about Medicare and Medicaid is Medicare is a federal program, right? So you get federal funding. Medicaid is a local program. So you get some federal funding, but you usually have to have a state match. And in the state of Maryland, we have not gotten to the point where we've applied for an 1115 waiver. I think part of this has to do with how is the state going to match those funds when it comes to social needs. So we can get a 50% match from the federal government, but then there's the back end of this, right? Is the state needs to come up with that money in order to fund social needs. So currently in the state of Maryland, the MCOs, the 9 MCOs, are not getting reimbursed, or, you know, the rate of SDOH cost isn't being included into our capitated rate. So we don't have money that we're getting paid for to address social needs. That being said, many of us are doing it because there is pressure when it comes to our accreditation. So NCQA requires you now to be health equity accredited. It was written into our contracts. So in order to provide health equity, right, you have to address some of these social needs. So again, making a case for a social bond and some vehicle of funding for us to be able to support the needs of the people we serve. Some of the work that we've done at Maryland Physicians Care is we started looking at data and trying to identify who in our population out of the 245,000 actually has social barriers, and what are those social barriers, right? We need to figure out how do we stratify our population because we have limited resources, and then figure out on an individual level, how are we going to assess the needs of that population? We can screen them, but it's going to take forever to screen 245,000 people. So a lot of the health plans, a lot of the focus year over year has been on the complexity, right? How sick people are, as well as how much are they costing us, right? But this concept of looking at social needs hasn't really been investigated up until recently. And COVID really shunned that fleshlight on it. So what we decided to do was we decided to use Maryland specific data to create our model internally. Many of the organizations will contract with a third-party vendor. There's many of them out there, Zio Omega, you know, socially determined and so forth. But the model that they use tends to be, hey, we're going to use 100 million live, right, data set, and then we're going to put it through machine learning, and we're going to create an algorithm, and then we'll push through the state data, right, or the MCO data. Challenges is when you're a microcosm like Maryland, right, we're small, we have a lot of micropopulations that have variables that don't rise to the top. And so we can't get that precision that we need if we're using a nationally based model. So we designed our own, and that's allowed us to actually identify hotspots throughout Maryland where we can now start going deep. So we go boots on the ground and we start screening the high risk population. The challenge becomes is we don't have curated networks, right? There's no guarantee that the resources are there, even if you do identify things like food insecurity and transportation and so forth. So another element that we've done is we've divided our population and then created 5 teams of social workers and community health workers across Maryland to really focus on the needs of the local population. The people that live in Baltimore City, which is, you know, like any other city, like New York City or Chicago or so forth, are very different than the people in Western Maryland that live in the Appalachian Mountains, right? They're going to have rural needs. They're going to have different barriers to access. So we needed to have local teams that really understand the needs of the population. We've also brought in a technology platform in order to be able to screen. And then what we've done, which is very different than what other health plans have done, is we started curating local networks reflective of what the needs of the population are to make sure that we're actually scratching the surface here and making some progress. So I'm going to show you a quick example of what this looks like. In Western Maryland, we identified that we had several hotspots that food access was a big issue, and it was a lack of grocery stores. There was also limited access to WIC vendors, and there was a lot of risk when it came to diabetes because we had food deserts, right? So people are eating whatever they can, often high in sodium, lack of produce, lack of, you know, nutritional values. So we also realized that when we were looking at our fulfillment rates, when we were screening people and connecting them to food resources, only 48% of the people that we screened and identified a food need were able to connect to a food resource. Additionally, only 17% of those were actually having their needs fulfilled. So we started looking at what are the challenges, right, to getting those needs met. Goes back to the funding, right? Increased number of people with no additional resources. There's a lack of sustainable funding. And, they're going to the community-based organizations, which is what CBO stands for, but there's no increase in capacity because there's a lack of funding. Significant reductions in SNAP. I just spoke to a gentleman yesterday who was getting $260 in SNAP benefits a month, and it's been cut to $26 a month, right? Huge difference. And part of this has to do with the redetermination of income levels. Now, the emergency period also expired, so it dried up a lot of the funding that both people were getting, but also the community-based organizations have. We've also had an increase in food costs, which has reduced the buying power. So this is kind of all coming together, right? It's a house of cards that's tumbling as a result, and the need continues to go up. There's also new eligibility requirements by the Department of Social Services regarding who we can refer and if they need to go down in person and fill out some information. So now we have another barrier of access. So even though it's a food problem, if we don't have transportation, now it's a bigger challenge. So what we did was we started looking at food as a multifaceted insecurity. And please know that what we've done for food, we're doing for housing, we're doing for transportation, we're doing for workforce development, and so on. And each one of these, pillars requires funding. So food is a lens that I'm giving you, but this is a bigger problem across the board because people have different needs. And often, if you're socially insecure, you have a multifaceted of needs. It's not just food, it's housing stability, it's workforce instability, it's transportation issues, and so forth. So do you live in a true food desert, right? That's an access issue. The eligibility and SNAP and the reduction of funds, I've already shared that, but you may be eligible for SNAP, but you have no additional funds or transportation to access what you need, or you have no access to healthy produce. So we went down into one of these small towns and spent 2 days. And what we found was in the city of Barton in Western Maryland, the resources, they would have to travel to neighboring towns. They don't have a grocery store, they don't have a gas station, they don't have a transit station, they have nothing, right? And so people are literally surviving off of what the neighbors who have cars can bring in, or the food pantry or the mobile markets that come to their community. We insure about 75% of the people in Barton. So for us, we're seeing their health outcomes continue to deteriorate year over year. So we looked at what does it take to get to the neighboring towns. Now, those neighboring towns are much better. They actually are living off dollar stores and corner markets as well. So it's not like they're prospering either. So we looked at the transportation. Well, they have one public transit option, which is the Purple Line that runs Tuesday and Fridays from 8 a.m. to 12. We spoke to about 100 people in Barton and nobody could show us where that bus stop is. So basically it's on a map, but nobody in the community knows where it is. And we're not really sure that there is a Purple Line that's actually actively running. The rideshare network is very slim in the region. And if you want to use that, it's going to cost you $52 to go 4 miles, which is basically what's the purpose, right? At that point, because if you've got $52, then chances are you can buy your food, right? And you can afford other things. With that being said, we tried to do an Instacart pilot, right? So taking people to the food is not an option, it's too expensive. So how about we bring the people food, right? So we outreached about 300 MPC members in Western Maryland, and only 39 households were willing to participate. Part of it was, even though we were paying the delivery fees, the Medicaid members were still asked to provide a secondary form of payment, and they needed to tip the drivers, and they needed to have that secondary form of payment for non-SNAP items. So what would happen was they didn't want their, untrusting, right? We've seen, people's information get stolen, right? So ultimately, they didn't want to put that secondary form of payment in place. And the drivers would come and do one delivery and they realized that their tips weren't great. And so they'd never come back to the house. And so it's been a very difficult pilot, but we had a lot of learnings. So what we've actually done is partnered with another organization, which is a nonprofit, America's Hauling for Hope, that was founded in 2017. They provide delivery and services to the household. They have served over the last Since 2017, almost 2,700 individuals in their community delivering food boxes. Because the other challenge is you can get to a food bank in many areas, but if you don't have transportation to the food bank, right? Now, how are you going to get that resource? So, for example, the Western Maryland Food Bank is located in Allegheny County, and it serves Allegheny and Garrett County. From Allegheny to Garrett, it's an hour drive, right? And there's no delivery mechanism to get food boxes out to the community. So we have now partnered with them. We've also done a donation of $160,000 to the Maryland Food Bank to repair the roof, because a lot of the community-based organizations are disheveled, and so they need this additional support. With that being said, we also found that the Maryland Food Bank wasn't sourcing any of the produce locally. So you have produce that's coming from Southern Maryland and other states being driven often 5-6 hours, and by the time it gets there, it's no longer good, right? The produce needs to be used that same day or needs to be thrown away. So part of our strategy is also to source from local farmers, but we don't have a sustainable way of doing this, right? I mean, I was lucky enough to get some funding from our board and some of the foundations in order to get this stood up. But if we want to address food insecurity, these are the ways that we need to get creative. Those food boxes also become a mechanism for a pathway to stability. So it's not just bringing food, is that food box now becomes a trust builder and a mode of communication. So the work that Hauling for Hope is doing is they have financial literacy as a requirement for receiving a food box. They're also putting in additional programs, right, in those food box to let them know about HEDIS campaigns and prevention and wellness campaigns. And people are going to be more apt to trusting what's coming in that food box because you're helping them create a path towards stability. And then what we're developing now are these wraparound services, career workforce development, hooking them up with a social worker and community health worker so that they can start building their life, back up, and that they can start thriving. Additionally, what we've done in order to source and provide healthier options is Hauling for Hope has this Greener Tomorrow project. So in order to supplement those food boxes, what we've done is done a donation to them of $11,500 for them to build 2 full-scale greenhouses and produce year-round, and then supplement the boxes. We've also applied for local grants to create community gardens to teach people, right, in their local communities how to grow food, but then also how to can it, right? And so we've done this with the University of Maryland Extension Center. And then the last program that I will highlight will be this hydroponic initiative. So this is one of my favorite programs. We partnered with a school that provides education and vocational training to special needs students, ages 14 to 21. And many of these students are actually MPC members. And we did a $15,000 donation, which has allowed them to now start growing through hydroponics and learn, other programs, get them engaged in STEM and stimulating through learned experiences. They're now growing an average of about 350 plants. So like lettuce, basil, radishes, they do cycles, and they're supplementing the local housing authority as well as the food boxes that Hauling for Hope is going out and delivering. So, I think this kind of makes a case to what Richard was saying about the importance, of getting this funded and some creative and innovative ways that we're trying to solve while building up the local community as well. So, Richard, I guess I'll hand it back to you.
Fantastic. So I think we're ready for Q&A portion of our webinar today. If that sounds good to our Minnesota team, we do have a number of questions submitted into our Q&A box, and so let's see if we can work through as many of these as we can. The first one, just a question asking for to reiterate the definition of the special purpose vehicle. I think that's the actual social bond that you're talking about. Would someone like to just give us a kind of a redefinition of that particular financing vehicle?
Yeah, absolutely. And first of all, thanks a lot, Lorena, for the excellent presentation. I think it's just incredibly useful seeing the excellent work you're doing in actually trying to implement these sorts of interventions and the evidence we see so far. Yeah, so the special purpose vehicle, just to define it, the idea behind it is that any sort of financial instrument has to come from some sort of organization. And so we can think of, like, say, a company issues stock on the stock market. It's just based on one company. Here we envision multiple organizations jointly issuing something. And so the special purpose vehicle is just to have something attached to all three organizations and kind of serves as an intermediary. Other than that, it really doesn't have any particular purpose.
Fantastic. Another question asking for clarification about the incentives that face investors to invest in the bond. And so can you clarify the incentives that face investors? Is it the promise of the MCOs paying investors back for any savings accrued? You may want to clarify actually who is the investor, because I think the MCOs are envisioned as the investors as well. So any clarifying marks you guys want to make on that?
Yeah, absolutely. So the idea behind this is that the investors we envision would be people like myself, like all of you. So basically, in the same way that you can go out in the stock market and buy a stock or a bond of a company, we would envision that you can go out and buy the bond. And so the idea behind it is that by buying this bond, you're providing money to the MCOs to make these sorts of SDH investments. And what the investors, you and I, would expect in exchange for buying this bond is that we're paid back some amount of money over time. And so that's kind of specified in the contract. You're getting some money that you're paid back over time. From the MCO's perspective, this would come from the cost savings. Now, one thing I do want to mention here is that I think another appealing thing for the investor's point of view is that investors nowadays are very hungry for some sort of investment that does some sort of good. And I think that this is potentially a very attractive thing with this sort of structure. We have a lot of investors that are really just hungry for something like ESG, environmental, social, and governance sorts of investments, just some sort of investment where they can make a rate of return, but they can also do some good for the community, for the world, in terms of fighting climate change or solving some sort of issue. So we would envision something like this as also appealing to those sorts of investors.
Fantastic. I might take moderator privilege and just ask a related question on that. Based on the bond structure, so in some sense, you're shifting financial risk from the MCO to the investor, the risk associated with the SDOH interventions actually working or not. Do you envision any moral hazard associated with that, removing the risk from the MCO and having that risk placed now borne by the investor, particularly since the MCO is presumably going to be responsible for implementing the SDOH intervention? So any moral hazard concerns there, or other thoughts about how to mitigate that?
No, great point. The short answer is that yes. I think with any sort of structure, even with a normal financial instrument, there's always concerns about moral hazard in exactly the way that you're describing here. One part of it is that yes, we would envision some risk being shifted from the MCO to the investors. But in terms of getting past this moral hazard, there does have to be some sort of skin in the game from the MCOs where they're on the hook for something. Now, we don't answer this in the simulation. I think this would be kind of something for future work to consider, but it would certainly be a consideration.
Fantastic. Another question asking about more information about the underlying population you're using for the simulation. Is it based on Medicaid data in an expansion or a non-expansion state? Does it include kids or adults? Any more details on that front?
That's a good question. I believe this is just the general Medicaid population, so we don't split it between expansion states and non-expansion states. That's, I think, a good thing that we could do an analysis on, kind of seeing, hey, here the effect would either be stronger or weaker, depending on which of the two scenarios we look at. Also kind of separating out the population.
Very good. Another question, wondering whether your model could generate more predictable outcomes if you can standardize the SDOH investment strategy, such as pre-selecting a few well-defined SDOH interventions versus having a more open-ended approach. Any thoughts about that I guess is an issue of kind of how you target the funding to specific SDOH interventions.
Yeah, no, this is a fantastic question. In our model, we are completely agnostic about exactly what the investment is. I think that the work that Lorena is doing in terms of actually providing evidence of this is critical for kind of answering this question in terms of saying, hey, we have some specific evidence of, you know, the example she gave with transportation and providing food and so on and so forth. They can give some numbers for what the impact is and then kind of seeing what strategy would be the first place. So absolutely, I think basically if this were implemented, we would want a specific well-defined intervention. And I think it kind of, the starting point is the work that she's doing.
Excellent point. Yes, Lorena, you gave us some really concrete examples about types of SDOH interventions that you're developing and investing in there in Maryland. So really, really helpful to hear that. Question asking whether your model accounts for the fact that the benefits from SDOH investments may not accrue to all patients in the MCO due to either eligibility issues or maybe just variability in uptake. Like not all enrollees take up the intervention, or a variation in participation. Any thoughts about that issue?
Yeah, the short answer is yes. So we have run some sensitivity analysis where basically the effect of the intervention varies by patients. And so you have some patients where it's a stronger effect, some patients where there's no effect or less of an effect. We also have a version of this where just patients drop out from the market as well. You know, they don't just churn between MCOs, they go from, you know, from one and then just disappear from the marketplace. Basically, the idea behind this, just at a very high level, is that there's still an economic case for this, and so it's still basically positive NPV from a financial point of view. It's still economically viable, but it does weaken it on the margin. And so kind of the extent of this, you know, for example, if you have a market where this is a huge problem, it does reduce the attractiveness on the market, on the margin, but overall it still works.
Fantastic. Another question, can you clarify the metrics that would be used by investors to justify the return on investment in this kind of a bond? Is the metric around improved health or some other type of metric that would be used here?
Yeah, that's a good question. I think the feasibility of this, and I think Lorena could potentially speak more to this because she's actually been tracking this. But in the model itself, what's happening is that the health is improving due to, say, the improved transportation, and then that's providing health savings over time. It is an open question in practice as to, you know, how do we actually track health over time and attribute it to a particular intervention.
I can provide some insight on that too, Richard. So, you know, just to be clear, the model that Richard presented, we haven't adopted. We are talking about if we get, you know, additional funding, you know, whether it's through the Robert Wood Johnson or other means, right, of taking maybe some of the programs that we're doing and doing some simulations around it, right? Because now we have an actual population distribution, we've got an intervention, and then we can kind of create a fictitious social bond, right, and look at the rate of investment. What I would share is that we just did an ROI analysis, and we're actually doing a three component ROI analysis at MPC. We're doing a pre and post intervention. We're also doing bending the cost curve with ACG, with the ACG model. So looking at the predictive cost and then seeing whether or not we actually bent the cost curve. And then we're doing a difference in difference. So by the end of, you know, or by mid next year, we will have results to be able to say unequivocally, right? Like all three across the board, you know, we've shown cost savings. That being said, we just ran our cohort through. And what we found with the leading indicator is that we're saving an average of about $87 per member per month in a Medicaid market, which is unheard of, right? I mean, like we have such slim margin. And it's due to the way that we've designed our entire model, not just the food component, right? The screening, the social risk identification, you know, and we're also doing some sensitivity and specificity on the risk score to continue to change the weighting system. We've applied for an NIH grant with UMBC. So there's a lot of opportunity around this. to get, you know, some more concrete numbers, but $87 per member per month saving is not a bad gig, you know, given the fact that the healthcare costs are so much, you know, when it comes to this population. So I don't know if that helps or hurt Richard, but you know, I think we have an opportunity to continue to partner. And well, somebody gave me a shock face. So again,
That is remarkable. Those are remarkable
Yeah, it
yeah.
really
results.
is. Yeah.
and what's more remarkable is that 2 years ago, 25 months ago, I was handed 2 PowerPoint presentations and asked to build a program. So this has all been done in
If we didn't get to your questions, look out for our follow-up email, or feel free to contact us at Systems for Action. We can connect you to the research team for more information. Hope you will attend future upcoming webinars from our Systems for Action program, and best wishes for the rest of your day. Thank you so much, everybody, for joining us.